I'm going to turn over the mic now to Kayte Spector-Bagdady, who's going to walk us through the next section, which is just going to be more of an open discussion. Part of it will be remarks in the panel, but we also want you guys to engage as well with some questions at the end. And, you know, Kayte is you're the co-interim director now for the Center for Bioethics and Social Sciences and Medicine here, as well as a professor in the Department of Obstetrics and Gynecology. And it's great to have her here. She's a national leader in how we think about particularly data sharing, but then also diversity in research as well. So, Kayte?
Good morning, everyone. Thank you. That was a great setup. I just want to reiterate everyone's welcomes from this morning and say how excited I am to introduce and moderate our next panel for the U of M Precision Health for its 5-year anniversary. My name is Kayte Spector-Bagdady, and I am Health Law and Bioethics faculty in the Department of Obstetrics and Gynecology and our acting co-director of our Center for Bioethics and Social Sciences in Medicine. So the national focus on precision medicine nationally, again, was really catalyzed in 2016 when the Obama White House announced the Federal Precision Medicine Initiative, along with then Vice President Biden's Cancer Moonshot. At the time, I was the Associate Director for President Obama's Bioethics Commission, where we focused on 2 issues the President felt were of particular importance to pushing precision medicine forward: the ethics and regulation of genetic testing, and returning incidental or secondary findings back to our research participants. The intent was to set the stage for a future of precision medicine which reflected the dual goals of pushing research forward, but also making respecting participants and benefiting patients centralized components of those efforts. Before Obama's announcement, the National Institutes of Health had formed a Precision Medicine Initiative Working Group in 2015. As part of their final report, they visualized that a core component of the Federal Precision Medicine Initiative would be a research and data biobank made predominantly of citizens who have been historically excluded from beneficial, federally funded research. Originally called the Precision Medicine Biobank, they quickly rebranded to the more palatable All of Us Research Program. As you can see, the All of Us Research cohort has achieved a high degree of participation from people who are underrepresented in biomedical research, or UBR, as this slide shows, especially by self-identified race and ethnicity. But All of Us continues to be constrained by their relatively low enrollment numbers, as you can see, if the expectation is to support big data research, particularly given the heterogeneity of the cohort. This brings us to the critical importance of tandem efforts in precision medicine at the individual institutional level. Institutions like research universities are often more nimble for experimentation in best practices and quality improvement than the federal government. Between its emphasis on collaboration and interdisciplinary research to patient-centered outcomes, ensuring advancements of science as well as patient care, the University of Michigan is a leader in this space and is expanding a version of precision services that goes beyond medicine to embrace all of health. And in addition to the wonderful advances in research and education that Brahmaji was discussing, UM Precision Health demonstrates a deep commitment to ensuring that this research is not just robust, but translatable across diverse patient communities, building on the success of the Michigan Genomic Initiative to broaden to my part, as he mentioned, and the recruitment, engagement, and retention of a large, diverse community of consented participants, helping to build Obama's vision for the precision medicine nationally from the ground up. UM Precision Health has, time and again, not just set the standard for precision care, data sharing, and research at U of M, but nationally, and all are looking forward to what we can accomplish over the next 5 years. To help us envision that future, We have with us today 3 leading experts. Dr. Amy Cohn is an Alfred F. Thurneau Professor in the Department of Industrial and Operations Engineering at U of M. She also holds an appointment in the Department of Health Management and Policy in the School of Public Health. Dr. Cohn is the Faculty Director of the Center for Healthcare Engineering and Patient Safety and serves as Chief Transformation Officer for Michigan Medicine. Her primary research interests are in applications of combinatorial optimization, particularly to healthcare and aviation, and to the challenges of optimization with multiple objective criteria. Welcome, Dr. Cohn. Dr. Santhi Ganesh studies the genetic and molecular basis of vascular diseases. She completed postdoctoral fellowships at the National Heart, Lung, and Blood Institute, the National Human Genome Research Institute, and Johns Hopkins School of Medicine, and the Institute of Genetic Medicine. Her lab has continuous extramural funding, and she serves on multiple grant study sections and the JCI Insight Editorial Board. She directs the Michigan Biologic Research Initiative in Sex Differences in Cardiovascular Disease program at the Frankel Cardiovascular Center, which aims to bring together researchers from diverse disciplines to identify and study mechanisms of sex dimorphism underlying cardiovascular traits and diseases. Welcome, Dr. Ganesh. And last but not least, Dr. Daniel Hertz joined the Department of Clinical Pharmacy in the College of Pharmacy in April 2013. Interested in developing tools for individualizing cancer treatment, his current work focuses on the optimal use of taxane chemotherapy in patients with cancer. Dr. Hertz is also interested in understanding the influence of patient genetics on cancer treatment outcomes, with a particular interest in the clinical translation of DPYD testing to ensure safe chemotherapy dosing. Much of this work is conducted in collaboration with medical oncologists at U of M Rogel Cancer Center and within the National Cancer Institute's National Clinical Trials Network groups. So please join me in welcoming these 3 experts. And so what we're going to do is we're going to take some time until about 11 o'clock, where we're going to have some directed questions that sort of we came up with collaboration from our community to ask these experts. And then we're going to open it up to questions from the audience. So much like Brahmaji mentioned before, please feel to write down any questions or comments that you have on your piece of paper and pass them to Erica in the back, who will gladly collect them from you. So you can just raise your hand and they'll come grab it. Okay, so to kick us off, Dr. Hertz. Do you guys want to make sure the microphones are working before I put you on the spot to answer questions?
Hello, mic check.
That's good. Okay. Dr. Hertz, why don't you start us off with what you see as the overall benefits of precision health resources to advance science?
Yeah, I think that a lot of that has been covered in different perspectives this morning. So I think for someone like myself who needs large cohorts of patients with linked genetic and clinical outcomes data, the fact that there is that cohort, that large cohort here, really makes my research a lot more efficient. So anytime we have sort of an idea, we can look through Data Direct, which is offered by the Precision Health, and we can figure out how many patients have genetics and how many patients have received the drugs of interest, and we can quickly figure out, is this a viable study that we can do in the matter of a couple months, whereas at my previous positions, if we want to do something like that, we would have to start by figuring out how many patients are going to get this drug in a given amount of time, that we can actually access those patients, collect that data, and get samples from them, and have to figure out how we actually generate the genetic data. So just the fact that the data is there and it's free of charge has really accelerated my research and allowed us to do a lot of retrospective association testing with treatment outcomes very efficiently. So that's sort of the biggest advantage for people in my space.
Yeah, same question. Okay. So I have been heavily accessing the Michigan Genomics Initiative genetic data. I think most, if not all, of our genetic studies on a particular set of diseases that my lab is working on have utilized MGA data in one fashion or another. all the way from rare variant identification for a vascular disease called fibromuscular dysplasia. Happens to be a disease that has been kind of historically neglected. 90% of patients are women, and so there's sort of a disparities aspect there in terms of how that disease has been approached research-wise previously. And we were able to enroll our own patients into a collection of samples, pair that with MGI data, really leverage the data set in multiple ways. And the results of that work range from defining first actionable genetic variants for the disease all the way to polygenic risk that we've been able to use to identify patterns of disease, relating many diverse vascular manifestations within a patient, a really poorly appreciated cause of heart attacks in young women that was previously really not getting much attention, and we've identified new markers for that. And relationships to other diseases, so things that we really hadn't thought of but could just explore in the data set and then take that out as hypotheses generated and test that in larger cohorts with collaborators across the world, really. So very enabling of the kind of work that we were trying to do. If we had to enroll our own controls for our study and enroll one by one going through this, we'd still be at it. We wouldn't have the progress that we have to date. We were able to, I think, get at 20,000 individuals just like that, get the data, impute it, clean it up and use it. And that's really, we've found new biological targets and we're working on that. So just as an example of what we've been able to do, I've participated in other studies using the MGI resource similarly with a very nice pipeline that's pretty user-friendly. We've used 2 different workflows. Happy to share those with anybody who might be interested, where you can bring in your own samples data or use purely MGI data. And the pipeline now with the data analytics group is very, very user-friendly. So, with that, just want to express my gratitude for the MGI program and all of the resources that we've been able to take advantage of.
So, I was very nervous coming into this morning, and neither of you made me feel less nervous in the sense that I think you both have articulated so beautifully how precision health contributes to work that you sort of started out with, and that work that you would have done otherwise, but done perhaps more slowly, less efficiently, more delayed in your outcomes. I come to this as someone who did not start in either disease diagnosis or treatment. I am an engineering faculty member who works in operations, and my time is split between teaching, and again, in the engineering space, healthcare research that is much more operations focused, and then my work in Michigan medicine, again, operationally. But I was involved with precision health from the very beginning, and what I have found to be enormously valuable, I think, is a little bit more of a meta layer that I want to talk about, which is that there are opportunities through precision health for folks, again, to really accelerate and enhance the amazing work that they were sort of on path to do to begin with. I think what we have seen blossom through precision health is a bringing in of additional people who weren't already working in that space, who didn't feel comfortable working in that space, and who had a lot of limitations in how they would work. And so I want to highlight a couple of things that, Brahmaji frequently pointed to things that many of us in the room take for granted and beyond this space are not so obvious. So what might not be obvious to some of you are issues about how do we work collaboratively across really diverse spaces. When you take someone who is in an engineering field, and I'm not talking so much about biomedical engineering, but the industrial engineers, the computer scientists, the folks who don't have the clinical domain, the value of having a space to identify problems where we have tools that might not have been known or might need to be developed, I think is an important opportunity. The ability to steward data and to understand how we protect the privacy of data, the integrity of data. How do we look at data and understand whether or not it is equitable data source, whether we are interpreting the data right? It is very easy to teach an engineering undergrad the basics of machine learning. They can develop excellent statistical and technical skills, and there are questions that you know to ask as a clinician because of the domain expertise. But there are skills to be brought in as well on the technical side from School of Information, from computer science, from data visualization. And so I think part of what, for me, Precision Health has brought in is resources and opportunities to learn and then to be able to teach. How do we steward our data properly? How do we access it? How do we handle it? How do we manipulate it? And how do we present our results in a meaningful way? And how do we work across disciplines? I think that's something that we can sort of talk about, the value of multidisciplinary work. We can say, I'd love to work with someone in another field. How we actually do it is not something to take for granted.
Is it working? Yes. Okay. So thank you so much. So you guys already talked a little bit about how precision health resources have impacted your own work, but I was wondering if you could delve a little deeper. Sorry, beautiful orchestra music. Delve a little deeper into some specific case examples of perhaps things that you've been able to accomplish with precision health resources. So Dr. Ganesh, do you want to start us off?
Sure. Happy to go into maybe more depth of what that research was. You know, I want to highlight up front that I'm talking about this as if my lab or we've done it by ourselves, but really it has been collaboration really facilitated through the connections, I think, with Precision Health and across the different campuses, and echoing some of the comments earlier about just what a collaborative place Michigan is, and how, you know, as a new investigator coming here about 10 years ago, you know, was able to establish those collaborations, made new ones along the way, and key collaborators at the School of Public Health, Dr. Zhou, who I see is here, as well as bioinformatics and human genetics and many groups. The Taubman Institute has funded quite a bit of our sample collection, and so maybe that's what I'll highlight as an example where the lab has, so my lab in particular has an interest in vascular diseases that disproportionately affect women and don't fall into kind of these traditional categories of atherosclerotic disease. And so I see patients in clinic, enroll those patients, my colleagues see patients, we enroll those patients through work that's supported through the Taubman Institute program. And simultaneously, we've been able to collaborate with multiple centers seeing patients with this relatively infrequent disease, get those samples, have them sent here to Michigan. And key things that we had were blood and saliva samples. We also have tissue samples. We have cells we're growing from those and doing lots of different things. But in order to kind of get your first discovery, I'll use a discovery case example, we can take all of those samples, derive the DNA, and subject them to genotyping with a GWAS chip. Those chips are things that we went to our friends at MGI and said, you know, how are you negotiating the cost of this? Which version are you using, et cetera? That information was very openly shared with us. Thank you, Sebastian. And we're able to benefit, you know, to get more samples genotyped, the more cost we're able to save, and fed our samples into the advanced genomics core alongside MGI samples and got our genotyping done in a way that should be very consistent with what the MGI samples were that we were combining with our data. So then on the other side of that, computationally, you take that data, you can call variants together because you've done uniform genotyping, you can clean the data together, you can impute it together to get a lower frequency, perhaps rare variants, and then conduct your association studies using really great infrastructure here that, you know, now there's the pipeline that I mentioned earlier, where you can put your samples through and have a GWAS that's pretty well controlled run. We are combining this with sequencing data and other things to develop polygenic risk scores that are perhaps more informative. But there's many things you can do with that data, but those first, you know, how do you get from the patient to a discovery? That relied on a lot of MGI resource to have happen. And so, you know, more examples of what you can do downstream. Some of those GWASs that we ran actually yielded very unusually strong hits, which is why we found them with a few hundred initial cases, then kind of spanned out to worldwide collaborations through meta-analysis and so forth. And, for one of the diseases we've studied, spontaneous coronary artery dissection, the latest meta-analysis is explaining about 70% of the heritability of this disease, something that was barely being recognized 10 years ago, much less, having anything known about it genetically, to a few years ago, we had our initial publication with some very strong hits, a new polygenic risk score that we've used to understand relationships to other diseases, and have found some very intriguing relationships. As an example, positively related to migraine headache, which we know many of our patients suffer from. So that suggests that the underlying biology may be shared, and an interesting inverse relationship to atherosclerotic phenotypes. So is there something about this that's protective against the kind of things that happen in atherosclerosis? So really generating a lot of important data to think about clinical relationships, how we're diagnosing these patients, the biology of these diseases. So a lot of output from the initial studies.
Thank you. So I'm gonna talk about a different facet, and I'm gonna talk particularly about the precision health component of the data support and the staff support in both accessing and interpreting data appropriately. I'm going to talk at a higher level than the cellular level, but the example I'd like to give is work with Dr. Alex Peel from obstetrics gynecology, and Dr. Peel is very interested in work on providing prenatal care, and particularly for women with challenges socioeconomically as well as clinically. And so a large part of her work is looking at what are the pathways of prenatal care, what are the visits and what are the testing and so on that need to be provided. And I'll give a very simple but sort of clear example. When I had my children, going to the doctors for a prenatal visit was kind of exciting. It was just a reminder of what was happening, and I would take the afternoon off from work, drive over, have a quick doctor's appointment, and maybe treat myself to some tea afterwards. I was not working at Kroger for minimum wage. It did not take me 3 bus trips to get to the doctor, and I was not at risk of losing my job by taking time off. And so that 5-10 minute clinical visit maybe isn't medically necessary for every person going through a pregnancy. And so Dr. Peel brought our group in to work on analysis and simulation to understand the operational impacts of what would it mean for our clinics if we started having patients go through these different pathways. And something that in some ways may seem very simple and turned out to be very complicated was gathering data on who is currently pregnant and being able to look at longitudinal studies and say, what is our cohort? Patients may be pregnant twice within the same calendar year. Patients may exit or enter the system at different stages gestationally. Things that you would think would be trivial to do. I just want to do a query on give me every patient between this time period and that time period who is currently getting care for pregnancy. Should be very easy. Many of you may be thinking, how could this not be easy? It was not easy. Erin is nodding. And in particular, it was not easy in part because my expertise was not within the appropriate databases. Dr. Peel's expertise was not in pulling the data. And Precision Health provided the expertise to be able to say, let us work with you to interpret what you need. Let us be able to pull the data for you appropriately. Let us be able to manipulate and massage the data as needed. And then let us be able to provide you with safe storage for what is often highly sensitive data. And so to me, whenever people talk about the benefits of precision health, I immediately think of the faces of the people who have actually done that support for us.
Thanks. So I'll highlight actually 2 related projects that are more in the sort of translation implementation space that we've been really excited about. So during the introduction, Kate mentioned that I have a real interest in this specific gene, DPYD, that predicts severe toxicity to chemotherapy. And because we have the MGI cohort, we actually know who at the University of Michigan or within MGI is a carrier of one of these variants. So we've set up a research project where we actually have an automated screen that runs in the background in my chart. And anytime one of those patients who carries one of those variants is diagnosed with a relevant tumor type or is about to receive these chemotherapy agents, we get notified as a study team. we can reach out to the patient and say, you're at very high risk of severe toxicity, and we can send them for confirmatory genetic testing and make sure that they don't get that chemotherapy agent. So that's sort of on the implementation side, and we're really excited about it. And we think there's a lot more opportunities for those kinds of things, although there are some sort of regulatory challenges that I presume we'll talk about, or at least I'll bring up a little bit later in the discussion, because I'd really like to figure out how we overcome those hurdles. The other project that we're excited about, so I mentioned that we know that there are patients who carry these DPYD variants. Currently, we have 4 or 5 of them that are confirmed to be low activity that increase risk of toxicity. There are hundreds or thousands of other less common variants that we've found that we don't have any information as to whether they are normal activity or reduced activity, particularly in non-Caucasian patients. So I've been working with Brett Vanderwerf and some of the other people at MGI to figure out how many of these variants do we have that are actually recurrent. We found more than 14,000 unique variants in the MGI patients that we have no idea if they are normal or low activity. And we've found about 30 variants that are exonic or splice site variants that are recurrent, that we think we have enough patients that we could bring them in and do some in vivo phenotyping studies because of the role of this enzyme in sort of normal physiology. There's a readout that we can get in terms of the activity level of this enzyme in patients that aren't even treated with chemotherapy. So we're really excited about that project. We're currently enrolling 150 patients that are carriers of some of these less common recurrent variants, and we'll be able to figure out, are those low activity variants, in which case we should add them to the panels and add them to our other project where we are actually intervening on those patients and preventing them from getting chemotherapy that can have really severe toxicity consequences. So we're really excited about those projects, and we think that there's a lot of opportunities for those things for people who have a specific area of interest and are aware of the depth of genetic data within MGI.
Great, thank you. And I think I'll just chime in because Ramaji made the mistake of giving me a microphone. But even as a lawyer and a bioethicist, so even as far apart from sort of the baseline of precision medicine as one can get, like I have been able to do my work enabled in this space by precision health colleagues and staff as well. For example, Dr. Weens, she and our colleague Nicholson Price from the law school were interested in sort of looking at some of the potential disparities and differences in recruitment and consent for our Michigan Genomics Initiative data bank. And so as a team, we were able to sort of look at sort of any differences between Michigan Medicine's patient catchment population versus who were recruiting to enroll in MGI, and actually found that we were much more likely to be recruiting sort of higher socioeconomic status, white, older men. And the reason for that was because we had been recruiting primarily in pre-op, which makes a lot of sense and is actually best practice to recruit from a cohort that has to give blood anyway for genetics, and actually is used as a best practice to recruit diverse communities. But because of where that was, we know that our patients that have access to surgery are more likely to be older white men. And then again, we saw, which is typical across the country, but once we approached patients, our Black and African American and Hispanic and Asian patients were twice as likely to decline enrollment as our white patients. So both at the recruitment and consent stage, we were losing demographic diversity as compared to our patient catchment population, which is largely white to begin with. And it was just really wonderful to work with that team, and I like to think that some of that research helped support my part and our, diversity of recruitment practices. And as Dean Runge said, he was very supportive in also developing a new data sharing platform, which we were then able to sort of publish in high impact publications, and then was adopted by the national academies in the report that Brahmaji was showing us, and I think really demonstrates that even somebody with as diverse a background as possible from your typical precision medicine practitioner, how this community and wonderful work with Erin and the other staff and Rachel really enabled this research that I do to be so much more impactful than what I think ethicists are only sometimes able to do, which is talk theoretically and philosophically, which is also important. Not to, I don't know if there are any philosophers in the audience, but I have a master's in philosophy. I support you. But just it's just an amazing, it's an amazing diversity of things that we can enable, and I hope it is another example of how we can build upon each other's work to improve it. So, Dr. Cohn, I'm going to come back to you, because you were talking about this sort of interdisciplinary baseline and how important it is at U of M and in precision health specifically to be able to accomplish these things. And I was wondering if you could talk a little bit more about how we can engage scholars who might not even see themselves as health researchers to begin with.
Thank you. Yes, I think this is such an important component. There's the things we know we don't know, and then the things that we don't even know that we don't know. And one of the great characteristics of this amazing university is the tremendous depth and breadth of knowledge and expertise. And one of the challenges of this enormous university is, how do you find the people that you don't know you need to know? And so I think there are many things that have happened very serendipitously. I think my relationship with Jenna possibly started when she was interviewing for a faculty position, and then sort of reestablished itself when my older son was looking at Michigan for computer science. And as you're having that casual lunch, you start to discover that there might be some interesting professional and research connections. And as I go through my 10, 15 years doing work with clinicians here, the vast majority of them tie back at some point to good luck and networking and events like this where you randomly sit next to someone. And I always encourage my mentees to try to maximize the probability of serendipitous connections. Sit next to people that you don't know. Attend events even if they're not immediately directly relevant. But those things are also time consuming and can be fairly low probability events, right? You have to chat with a lot of random people before you find a co-author sometimes. And some of us are more comfortable with that and some are not. And so I think part of what I see precision health as already having done, and a place where intentionality about doing more, is to see who those connectors are. As I've gotten further along in my career, I have certainly found myself moving from an individual junior faculty PI looking for someone to work with, and much more frequently saying to someone, that is an amazing idea. I'd love to brainstorm with you over a meal or an afternoon about that. And then let me introduce you to my friend Dan, who may be a really great person for you to work with. I think that precision health can, and I would argue should, be putting resources and incentivizing and rewarding the behavior of simply knowing what the different tools and domains and methods are across the spectrum, knowing who the players are, and starting to understand that you might not even know that a particular technique or tool or resource exists, so you don't know to go look for it. Who are the connectors to be able to say, I've been paying attention to what new things are being done in the School of Information and on data visualization. And I know what work is being done in pediatric, psychiatric, mental health, that these things might connect. Any place that we can be finding those connections and fostering those connections, and in particular pushing that down as low as we can. Right, so it's getting it down to the junior faculty, to the graduate students, to the undergrads who are working in a field and not realizing that there's an opportunity that could blossom that. I think we have seen, from a diversity standpoint, in a completely different lens, young women are much more likely to go into engineering disciplines that they associate with social good. It's obvious in biomedical engineering, it's fairly clearly defined there, but when you talk to an industrial engineering student about, it's not just manufacturing and supply chain, it's helping underprivileged women be more likely to have healthy babies. It changes the way we bring people into fields.
And conversely, I'm seeing pre-med students coming into my lab saying, I went into medicine, I started studying pre-med because I want to help people, and now I'm starting to see that there may be a different way, using skills and tools that feel more comfortable to me through engineering, to still be able to make contributions. And so I think it's just being intentional and putting resources into building those connections.
And so, Dr. Hertz, you mentioned previously sort of the importance of your research specifically and its translation into clinical care. And I was wondering if you could talk to us a little bit more about this translational trajectory that precision health has really enabled between science and its application in clinical care.
Yeah, I think that there's a great opportunity with the amount of data that we have here. So people talked about Jenna's project earlier with the prediction models, but even with the genetic data that I focus more on, I think that we have really demonstrated one use case of how we could use that genetic data for something that is implementable and actionable and can, and we know helps out and improves treatment outcomes. So I think that with the amount of genetic data that we have available to us, there are more opportunities for doing that. The question is, what are we allowed to do with that genetic data, and what is considered clinical care, and what is considered acting on data that is currently described as genotyped for research purposes, right? So that's sort of the major challenge, is because the genotyping isn't CLIA approved and because the patients don't consent for it to be used in clinical practice directly, we have some barriers there. But I think that there are several different pathways that we could use to do something that may or may not be considered using that data in an actionable way. So I mentioned in our study, we have kind of a research study built where we are notified when one of these patients who's a carrier of these variants is scheduled to receive that that drug of interest, and we can go back to them and enroll them on our clinical study and send them for confirmatory testing. And that's how we've kind of gotten around this being sort of clinical implementation. We've worked with MGI and IRB and figured out sort of a middle ground we can do that. But there was a mention earlier today about genomic indicators that go directly in the electronic medical record, and could we use the MGI data within those genomic indicators, or would that be considered using this for clinical care? If those genomic indicators just told the clinician, we believe this patient's a suspected carrier of this variant, perhaps you should send them for clinical testing, would that be a sort of middle ground that the IRB and the consent would all be, would be consistent with all of those sort of limitations on what we're allowed to do? So I think that there's an important conversation to be had about how we can do that, and we've tried to start having that conversation a couple times, but I think we realized pretty quickly that it's complex and it's going to take a lot of people and a lot of thought and a lot of work, and you know, it's sort of, and several lawyers, yeah. And I think that we've sort of had sort of fits and starts, and we haven't really gotten there yet, but I'm hoping that when people hear about our example and see that we can, you know, really intervene on patients and prevent unnecessary toxicities and deaths, that they would start thinking about other avenues to use the MGI data, and there would be more of a groundswell of the need for MGI and the IRB to work together to figure out what this regulatory framework looks like, so we can start implementing based on the information that we have. And I would love to contribute to that conversation, but it sort of needs to be led at the highest levels.
So I'm very envious of these clinical implementations, and we're not quite there, but we're working our way over there. I think we'll really benefit from hearing about these conversations. You know, we have return of results workflows, but it's not quite ready for prime time for clinical use.
Yeah, which I think is a great demonstration of why it's so important that there are so many people in precision health that do these different kinds of things and bridge these divides. Okay, so for those of you who have been writing questions down on pieces of paper and brilliant thoughts, now would be a good time to pass them to Rachel or to Erica, because this is our last question that I'm going to ask of our entire panel, and then we'll open it up. So Dr. Cohn, do you want to start us off on this one? Can you, so, you know, 5 years, that's great. We've built this huge pipeline. We've invested a lot of money. We've already seen a lot of results. Like, we've really hit the ground running. But for the next 5 years, so what are we going to be talking about at the 10-year celebration, right? What do you think the next 5 years is going to be like? What are the major things you think we might be able to accomplish?
What's going to be in Brahmaji's slides in 10 years, and what do you hope to see?
So they didn't tell us they were going to ask this one.
Oh,
That's okay. Or I didn't read the email. But I think it's actually better this way because I've been able to hear and think. What I would love to hear in 5 years. So I think we've started with a small group of scholars who do a fairly specific type of work with genetic data. And we've seen opportunity to expand that so that more scholars can benefit from the expertise, more can benefit from the data, more can benefit from the legal processes of working through this. We then expanded to include other areas of campus. We've expanded to include students in our certificate program, getting students involved in summer programs, all of this work. What I would love to see 10 years from now when Brahmaji stands up to present is the discussion of the patient and consumer involvement, and that a huge change has been the engagement, not just in a more diverse population providing data, but a real ownership and investment and engagement of the community in both advocating for what they want and contributing to the efforts. Because I think at the end of the day, an enormous part of what we haven't really talked about is the decision of what is clinically appropriate or ideal is in fact itself unique to the individual patient. And so I would love to see that this room includes members of our patient population in our community.
So in 10 years, I think the current focus on, can you hear me okay with this? The current focus on diversifying the resource is extremely important. And I'm quite convinced, there's good data to support it, that we will find more things, have better implementations, be able to tease out biology and really achieve all of the goals of the kind of discovery genetics work that we do. And I think we'll have a tremendous impact to be really intentionally diversifying the groups that we're able to study. Most of the studies I didn't share earlier that we've done have been done in individuals of European ancestry. Those are the samples we have. That's what we've been able to do to date. And it's been very valuable, but I think the next phase of really trying to inclusively study our patient populations and find things that will be broadly applicable. I've seen that focus here and heard that earlier from Brahmaji, and I think that's super important.
So I don't think I'm smart enough to know what we'll be celebrating in 5 years, but I think that we will have a lot more to celebrate if we continue focusing on the data collection. So we've talked a lot about how much we have used the genome-wide genetic data, but I think that my understanding is there are samples in the biobanks. We could generate proteome-wide data, metabolome data, epigenome data, lots more biomarkers that people could use for the sort of discovery science that we often do. And I think that's actually relatively easy, although I understand that nothing's easy, especially at this scale. But I think what's harder, and at least in my field, what would be more valuable is if we did a better job collecting the treatment outcomes data. So at least in cancer where I work, there's a major shift towards patient-reported outcomes, which just requires lots of surveys to be taken. So if we integrated those kinds of patient-reported outcomes into practice, and we had a lot more structured data on toxicities, on efficacy, on quality of life, on a lot of the things, because in my field, it's not just, was this patient diagnosed with whatever condition? It was really, did they get this drug of interest, and then what were the consequences of that? And right now we're doing this all sort of manually. We send students into the medical record to figure out who got the drug, and then what were their outcomes, mostly through the notes, and a lot of things eMERS and Data Direct are really helpful with that. But if we had consistent collection of treatment outcomes through sort of surveys, then we'd have a lot more structured data and a lot more uniform and consistent data that would be really helpful for the kinds of work that we do. So expanding the data collection both on the sort of independent and dependent variable side, I understand is challenging, but will be really helpful for us over the next few years.
Okay, great. So we've got some great questions from the audience. I am going to kick us off with this because I think this is something that's been mentioned a lot, but should certainly be part of the next 5-year vision. How is your work with precision health helping to reduce health disparities and advance health equity?
Maybe I'll actually start there. So I mentioned that with this DPYD gene, where we know that there are certain patients that carry these variants that are predictive of severe toxicity, the variants that we have that have been confirmed are really only recurrent in Caucasian patients. And there was recently a petition that we sent to the FDA to recommend or require this testing. One of the things they said was, this is just going to exacerbate disparities because we don't know what these variants are in non-Caucasian patients. So we have now gone into MGI. We have pulled a lot of the variants that are found in non-Caucasian patients, and we're specifically focusing on those individuals to figure out what are the recurrent variants, and can we confirm that those are reduced activity variants. If we can, then we can add those to the panels. We can figure out why it is that patients who are African American patients have higher rates of this DPD deficiency, this enzyme deficiency, and higher risk of toxicity. We just don't know what those variants are yet. So having the large MGI cohort, even though right now it's sort of underrepresented in those patients, we still have many thousands of non-Caucasian patients, and we can specifically look at what are the recurrent variants, and we can figure out what are the low activity variants that are causing them to have this toxicity risk. So I think that's a sort of perfect example of how not only we can do that at the institutional level, but then we can go back to FDA and say, okay, now we've figured out why there's risk in non-Caucasians and African Americans and Asian patients that we currently have no way of testing in them, and now we can say everyone should be tested regardless of race.
I think I've alluded to it previously, but probably the biggest impact has been being able to identify a biological correlate to a cause of vascular disease in women who typically are not being considered as having what would be the traditional risk factors for vascular disease, showing up with heart attack, stroke, severe hypertension, death, and so very serious manifestations of their disease, but really before the work that we've been doing was not really being explored. So we've been able to do that despite the bias in enrollment. We, had sex was one of the criteria for matching, and so on genotype inferred sex, we were able to find plenty of individuals within the MGI resource and conduct well-powered studies for our initial detection. So that would be the place that we've made progress to date, and as I mentioned, we have more work to do to diversify in terms of ancestry.
I've alluded before to the issue of data storage and manipulation, and for me, some work that actually bridged between both Precision Health and some Midas resources in a really nice partnership was looking at access to clinical care. And so again, it's a very different scale, but what we were asking was how much emergency department utilization could potentially be tied to people's lack of transportation, public transportation, to get to less urgent or emergent clinical care. And so one of the things that we wanted to study was if a patient was going to the emergency department, could you intuit anything about that patient and their transportation? So from my home to the emergency department is approximately 3 miles. And if I drive it at peak traffic time, it's about 7 minutes. And if I drive it at 2 in the morning, it's about 1.5 minutes. If I try to use public transportation to get to clinical space, it's 45 minutes at peak times, and it's impossible, basically, beyond sort of 8 a.m. to 8 p.m. So the challenge here was very much a data merging and therefore privacy. I actually needed to know patients' home address. That was the point. I needed to know the time of day, and ideally the actual date that they went to the emergency department because that would impact not only transportation schedules, but weather conditions. Being able to look at those in a way that felt safe and ethical and appropriate required an enormous amount of partnership, but I think was in fact a really important question as we think about what are the socioeconomic barriers of care. A big part of it is not purely clinical, but the transportation infrastructure.
Great, thank you. Erica and I were discussing sort of the pros and cons of writing down on little cards last night and whether we should be doing this, and then I just realized it's a room full of doctors, so you'll have to forgive me as I try to read these. I didn't think of that one before. Okay, so the next one is, I think, how should we approach data access through sharing of de-identified data versus creating cloud environments where data can be accessed selectively but more safely? It seems like NIH is developing both paths simultaneously. I guess I'll quickly answer this as a lawyer, because lawyers really like cloud computing, because if we're actually sending out data, we have to be reliant on contracts to ensure how the data are used, right? Once you send something out the door, it's just a like, pretty please, or we won't send you data in the future for re-identifying or for sharing with third parties. So from a lawyer perspective, cloud computing gives institutions a lot more control because no one's ever walking off with the product. But what about you guys as scientists? Cloud computing versus de-identified data sharing.
I don't think I have any real relevant expertise in terms of the technical aspects of that question. What I can say is, from our perspective, we understand the need for data security. So we use the server that's set up, the Yottabyte server, and we send our statisticians to it. I think that we find it to be somewhat cumbersome, but we understand that that's what has to be done for people to make sure that the data is being used securely and by the right people. So we work within the framework that we're given. I think, you know, we would love if you guys just sent us all the data we wanted without asking any questions, and we could do a bunch of science, but we understand that that's not practical, and that there are things that need to be done on your end to make sure that everything's done safely and securely. And I think that everything that's been set up has been usable for us. And I don't have any specific comments about cloud versus other frameworks. I just don't know enough about it.
So we work a lot with de-identified data sets that come to us, and the worries that you described, I also have as a PI of a lab. Sit every student down and talk about, this is a laptop, we're all remote during COVID. You know, you can't download this or whatever it is, you've got to use it in the space. So I wouldn't call that cloud computing, but it's a shared server. And I think, you know, that if I extend that concept and beyond my own work, right? So if there are people who have questions, but maybe not as into the details of how you take a data set, clean it, impute it, et cetera, yourself, if there's an existing resource that you can walk up to without having to know all of that necessarily, but know that it's there. There's a basic kind of infrastructure. There are people you can ask for questions if there's something that is looking strange or doesn't fit quite what the template might be, but then might actually improve access to the data, so that if you're a biological researcher, for example, and you have a specific question about that phenotype in humans and you're using that as a human experiment, you know, you can just ask the question and get your data. If you're on the clinical side wondering about, you know, what are the things that, you know, you might be able to do with that data set, the infrastructure you need as a PI to get that de-identified data and handle it appropriately requires some effort and consideration to implement. So the cloud computing, I think, would make things more accessible to researchers.
I would say it's an and, not an or. The times that Yottabyte or similar environments are most cumbersome in my mind are when you're trying to do something that is different than what other people have normally done. And so the flip side is where Yottabyte, to me, has tremendous opportunity above and beyond the importance of data protection, is sort of facilitating. So
I don't need to build my own server. I don't need my own database. I don't need to be able to manage a lot of these issues that you alluded to. And I think a hybrid model may be worth exploring, and frankly, I think it's largely what exists today, which is the default assumption is you're working in the cloud and you're working in Yottabyte, and if what you are doing can be done that way, it's actually safer and probably easier for everyone. If you want to do something different, this is now an opportunity for partnership, because in working together, on the one hand, what we're trying to do from the precision health standpoint is say, how can you do the thing that you need to do, whether it's merging multiple data sites that aren't all part of Yottabyte, whether it's using software or other tools that aren't there, to be able to facilitate that in a protective way. But that is also building up our knowledge. If I have 3 different people across the university not knowing each other, all doing what they think are unique things that are in fact one and the same, there's not only the opportunity to link those 3 scholars, but can that then go on the list of something that becomes part of what is a standard offering through Yottabyte? So I think it can evolve, that Yottabyte becomes more and more flexible, has more and more resources, without locking out faculty or researchers who are trying to do something novel, because we're requiring everybody to always be within that environment.
Yeah, I think that that's a great point too, because we've done a lot of studies interviewing and surveying genetic researchers, and I think something that perhaps we at University of Michigan, who are so highly resourced, forget is that you need a massive amount of computing infrastructure and storage to do your own analyses. And so if they're just giving you de-identified data, that assumes that you have the lab and the computers and the infrastructure to actually do those analyses yourself. And I know that one of the specifically articulated goals of NIH in trying to centralize this is also give people actually more access to analysis platforms and sort of even the score in that way. Okay, so another question for the audience is, how do we include patients and participants in governance and things like precision health, and for example, in meetings like today?
The question is how.
Yeah, well, it wasn't. It was actually more of a comment than a question,
okay.
But I phrased it as a question.
Okay. Yeah, I mean, I think those are our stakeholders in a lot of what we're doing. And so, we have worked with certain funding agencies like PCORI, for example, where you intentionally need to include, but we've partnered with patient foundations and patient groups and used that same channel to get information back about what happens on the research, because I think it's just a great way to engage the group and kind of give back as we're developing this new knowledge. So I support that it should be done. How to do it practically, I don't see a reason why a patient couldn't be invited to a meeting such as this. What we're talking about is perhaps a bit technical, but there are probably ways to translate that. Some of the meetings that I've seen been really successful with it is to have a specific patient day or session where things can be broken down a bit further, but then not necessarily protective of the other spaces where things are being discussed, so that people can participate if they want to.
Yeah, I think the how is just you invite them and you do it, right? So in the Cancer Center, there's a Breast Cancer Advocates Advisory Committee, and it's a dozen or so breast cancer survivors, and they've volunteered to set up this committee, and they meet monthly, and they're open to looking over projects and giving feedback, and I take most of my projects to them, and they give me a lot of help, and they give me really the patient's perspective and what matters to them and what would be feasible for them, and they have done some pilot testing of my apps and things. Like they've been really helpful in giving me feedback and telling me what matters to patients and what doesn't. I think at MISHAR they have patient advocates that sit on their panels and review grants, and you could do something like that. But I think you have 60,000, 70,000 local patients that have been interested enough in joining your cohort. So I think reaching out to them and saying, we're looking for 10 or so patients that want to continue giving back and be more involved, and you don't have to have expertise. We want you to come to our meetings and talk with us and give us your thoughts. I think that's, you just sort of do it. You prioritize it and you do it.
And I'll just again bring attention to the diversity of that group. How do you ensure that that group is not predominantly representative of privilege again? Right? Both in terms of people's ability to participate and in their comfort level and willingness to participate. I think, I'd love to learn more about how the Cancer Center, for example, I know has had some wonderful patient advocacy groups. And so not recreating the wheel, but understanding how do we make those inclusive environments.
Yeah, I think that's a great point. And Dr. Ray Hutchinson and Laura Sedig actually just came out with an interesting piece where they went to a community in Flint and talked about how to better engage people in research. And one of the things that many of the women contributed was that there are these breast cancer awareness community participation days that U of M hosts, and if U of M didn't send a bus to Flint, it was their perspective that there wouldn't be a single Black person that would actually make it to that meeting. And so that's transportation, again, is the example they gave. Okay, so this question is for Dr. Hertz specifically. I've talked with several people here who have used predictive value to assess polygeneric risk scores. In your assessments of cancer outcomes, what key measures do you utilize?
Sorry, could you say that
That's
again?
all it says. Okay. So predictive value to assess polygenetic risk scores. And if you're using polygenetic risk scores to predict cancer outcomes, what measures are you looking to?
I'll talk to a couple different aspects of that. So my understanding of the space and sort of polygenic risk scores is that it requires very large cohorts to find the right variants that have sort of low penetrance and low effect sizes and combine them in such a way that you can get a meaningful prediction out of them. In the pharmacogenetics space, where we need cohorts of patients who have received the drug of interest and have outcomes for us to do that sort of discovery, we're nowhere near the cohort sizes necessary to generate those polygenic risk scores, at least in cancer. I know I have a colleague, Jasmine Luzum, who does some of this work in Michigan Genomics Initiative doing polygenic risk scores in cardiovascular disease, where there are many more patients here because it's a more common condition. You have lots and lots, tens of thousands of patients on the same statins or blood pressure medications or those kinds of things. So I think in cancer, we're just not at the point of polygenic risk scores on the treatment outcome side. So it's not really something that we have thought too much about at this point.
Great, thanks. Oh, so this is for me. What are 3 methods, approaches you use to get over the recruitment hurdles in historically excluded populations? So that's a tough question, and I'll start with the hardest component, which is differences in informed consent rates, which we saw here at the University of Michigan and is true across any number of surveys and analyses that have been done across the country. There are people who have done really excellent work in this space on ways to build trust with communities or rebuild trust with communities that have rightly been broken due to racism. So for example, Mildred Cho and Ruha Benjamin have done a lot of great studies on the importance of community engagement and education and this relationship between research universities, which not here, but are often centralized in urban cities. And the challenge is that those kinds of methods are extremely expensive and time-consuming. And so a lot of people skip over them, which is one of the things that I at least was particularly excited about in Jenna and I's findings and our research team, that actually the method of recruitment was just as impactful on limiting demographic diversity as the consent rates, because recruitment is something that universities always look to, and recruitment is something that we can manipulate. And that's one of the things that I think is so exciting about my part, is actually taking this information and saying, oh, we designed it in this way for XYZ reasons, which we thought would encourage enrollment. We see that it results in these other kinds of disparities, and therefore we're going to completely change that. So I think that that's a really exciting area of easy growth that people can take on. The third area, which I think is often overlooked, where much of my research has been focusing, is on then encouraging researchers to use diverse data sets, right? because it's if we build it, will they come? If we actually build diverse data banks, are people going to use it? And in many of our interviews with geneticists, the answer was, well, no, because if you take all of us as an example, it has about 450,000 participants, 80% of whom are from historically excluded communities, but all of that 80% are from different kinds of historically excluded communities, right? So if I want to do research on Black men with diabetes and colon cancer, I need just not 10 or 15, I need 80,000. And so that's why all of us has often been used as sort of a reference database as opposed to sort of the main hypothesis generating database. But trying to build those databases and figure out how to encourage people towards them. In some data that we just got back from a big survey, people often say funding and access, and education on what data sets exist for access to, right? And so most of research and ethics has focused on how to change consent rates. So we know a lot about that, but I do think changing recruitment and then usage rates are just as important. I don't know if anybody else has comments on that.
I would just agree.
Okay.
I would say quickly, so I mentioned my study where we are trying to enroll individuals that are carrying these low frequency variants and specifically focusing on those recurrent variants in non-Caucasian patients that we don't know much about. And it was actually only in the past couple of weeks that we switched from enrolling our Caucasian wild type controls to starting to enroll some of the non-Caucasians who are carrying these variants of interest. And I was told by my study coordinators and my staff that they are having a harder time getting them to consent and enroll. And I asked them why, and they just said that they weren't interested in participating in research. So I think it'd be really helpful from the MGI perspective. I know that there's a process for the sort of re-consent approval through MGI. If you did have people on that staff that looked at this and said, if you are going to try to target non-Caucasians for the recontact to enroll in a follow-up study, you might want to consider this language. We found this works better, whatever those things are. We haven't figured those things out, but I think there's a sense that the participation in research from non-Caucasians hasn't led to discoveries that help non-Caucasians, so there's a lot of apathy towards participating in that research, whereas we're now doing a project that's specifically focused on helping those individuals. I don't know if I'm allowed to say that or how I convey that or how my coordinators convey that to individuals. We are specifically doing this looking for non-Caucasians because we want to catch you guys up and reduce the disparity in our understanding of this and help future non-Caucasian patients prevent this toxicity. But I don't know what we're allowed to say or what would be the most convincing to them, and it'd be really helpful if MGI had some staff and had some recommendations that could tell us, try it this way, because right now we are struggling.
Yeah, no, I think that's a great point. Well, and also the point that ancestral diverse research benefits everyone, right? So, the NIH GWAS database currently has about 4% of people who self-identify as Black or African American, which is often associated with African ancestry, but represents actually more than 7% of the variants which have been associated with disease, right? Because there's more ancestral and genetic diversity in populations from Africa. And so it helps everybody. It's not just, it's not just benefiting a specific community. Okay, so last question. Early on in MGI, there was a focus on opt-in written informed consent, right? So you actually say, yes, I want to consent, as opposed to sort of the default being that you are consented unless you opt out. This is time and staff intensive. Other institutions have worked in opt-out models, and where do we stand today? What about your thoughts on what you currently do and what you might do in the future?
I don't know that I have a clear answer to that one, but the opt-out models have been, from what I'm aware of at other centers that are doing them, more efficient in terms of accruing numbers. And then you have the EHR and whatever was obtained, blood sample, DNA. Perhaps from an ethics perspective, you can comment. my instinct is, as a clinician, for example, if my patient were enrolled in something, especially if results might get returned, if there are things that, could enter and we don't know what that is, I think being really transparent about that is super important. What that transparency could look like, to me, actually getting consent, tells you that you've achieved that, you've told somebody what you're going to do. If there are other ways to do it, it sounds perhaps worth exploring, but it's just an instinctive answer that, there are probably a number of things to check and really make sure that even if you think something is transparent, was it really transparent? Do people really know what this opt-out process is? How have you advertised it? Did they understand it? Were they in the emergency room when you asked that question and they didn't really hear it? Lots of things, lots of potential questions.
Yeah, I'm not sure that we have the ability to explain to the patients all the things that might be doable with this data later on. So in my study, if we had a patient who was a known carrier of one of these DPYD variants and they're about to receive this drug of interest, even if MGI told me they have opted out of return of results, I don't know that I could ethically allow them just to continue on with treatment and have an 80% risk of severe toxicity and a 3% risk of death. Like, I think I would have to intervene and say, I'll take the consequences. Like, this patient has to know that they are at extraordinarily high risk of toxicity, and that's just one example. And we would never put all the examples into a consent document. My favorite thing about MGI is the one-page consent document that just says, like, here's the overview of what we're gonna do. And it's such a complex question. I'm not the philosopher, the lawyer up here.
Yeah, no, I think that's a great point, Dan, about the return of actionable results. And actually that ended up being the policy of the Obama administration, that if there were some very specific, actionable, and clinically significant results, you were not allowed to enroll in the research unless you would agree to return of them. Because Christine Grady, who is the chief of bioethics at NIH, that was her exact point, was, researchers are people too, and there are findings where they cannot sleep at night unless they return them. And, it's voluntary to enroll in research, and it's a two-way ship. And then as to the opt-in versus opt-out, often that's analyzed on the basis of what the risk is. So for example, in organ donation, I think is the most classic example of opt-in in this country, because for whatever reason, culturally, we see the taking of organs from people who are dead or close to death, about to die, as something that has a lot of religious significance. And so culturally, we've sort of built that into our law. Whereas under the common rule and data governance, we can do research with de-identified and specimens and data without this affirmative opt-in. But shout out to the Office of Data Sharing and Erin and her team, who are continually working to improve both our participant consent as well as our patient consent forms, such that that kind of information is clearly at least delineated on the clinical consent forms. So with that, I will please join me in thanking our amazing speakers. This was really wonderful, and we're all excited for lunch.